I'll go on to our next presenter, Dr. ABHIJEET DESAI, who's again a practitioner, a very popular practitioner from Mumbai, from Soham Eye Care Center, and a very versatile surgeon. And let us see how he does his 4-minute video. On to you, Dr. ABHIJEET.
Thank you, ma'am. So this is about IOL exchange, which I had scheduled. We had operated his other eye, and which came up to 6.6 with the Clarion, and the left eye was unfortunately operated somewhere else 3 years back and had an error of plus 3.25. Patient had a lot of anisometropia and issues, so finally we advised him an IOL exchange. Now this is a dispersive OVD which I am using it to open the bag, but the bag doesn't open in all places because it's nearly 3 years old, and it's with a hydrophobic 3-piece IOL. So there are areas of fibrosis which I'm separating out with a blunt iris appositor. So those are the areas which need to be very clearly opened up, because otherwise we'll end up with a zonular dialysis in these kind of cases. We had planned with a 2.8 incision because of the astigmatism, and we plan it on the Varian, of course, and that's how we would decrease the amount of post-op astigmatism that the patient would have. Here I'm trying to rotate the IOL out of the bag, but unfortunately the IOL haptics are really stuck in the bag. There's a lot of fibrosis in the IOL in the bag, and making my life a bit miserable. So even though I'm trying all maneuvers, it refuses to come out. So I'm using a Sinskey hook to get the entire optic out of the bag. Even that's causing a stretch on the bag there. Now part of the optic is actually out, and that probably does not augur well when you are trying to rotate the IOL. So I put the optic back in again and then try to dial the lens towards the wound. Still, it's going to be difficult getting the entire haptic out. So what I do here is I just prolapse a part of it out of the bag and then cut off the haptic here. Once one haptic is out, it's easy to get the entire IOL out of the bag here. I'm using an IOL grasping forceps out here to hold the IOL and pull it out of the bag completely. Now here I'm trying to use a specially made scissor which I can introduce to a 2.2 for cutting the IOL, but unfortunately these scissors are very delicate, so many times they do have a malfunction. So it's always better to have another scissor in hand to cut these things. So I use a dispersive viscoelastic again, use a Osher's vertical cutting scissor, IOL cutting scissor, and I bisect my IOL. Again, the grasping forceps many a times get stuck with the IOL because they are a bit wider than the opening of the jaws. So it's good to use the Sinskey hook to remove the stuck part out there. And then you can always put the IOL in the bag. A good idea out here is to do a very precise cortical wash and capsular polishing, so that all the L-shaped pearls and the rest of the after cataract which is developed over a period of time come off, and that gives a good vision. I'm just showing this video also because this is an alternative technique of removing the IOL. So this is, I think, I had seen it demonstrated by Dr. Arup Bhaumik from Calcutta, if I'm not mistaken, and he uses this cartridge from the Alcon. He opens it up with a blade and uses this IOL snare to remove the IOL out of the bag. And there are multiple things which have been developed over a period of time. You can use the IOL grasping forceps through the same kind of a cartridge to remove the IOLs, and many other techniques. Like if I'm planning a toric IOL, I would do a quadrisection or a trisection of the same IOL using a very good dispersive viscoelastic. Thank you.
Thank you, Dr. ABHIJEET. That was a wonderful demonstration, and also the last bit. So let's just look at some questions related to IOL exchange. I would want us all to know that the challenge with getting the IOS out are more with the hydrophobic platform than the hydrophilic, because there's more adhesion which happens in the hydrophobic platform. But residual anisometropia of 3.25 diopters, I would want Dr. Swapna to comment on this. Would you consider primarily a piggyback IOL, or would you look at an IOL exchange, seeing the difficulty which she had removing it?
Why not do a laser?
Huh?
It's a
Why
plus.
not
It's
do
a
a laser?
hyper.
It
It's
is
a
a
hyperopic
hypero
patient.
plus 3.25 hypero.
Doesn't matter.
Doesn't matter.
Doesn't matter. You can easily do laser. I mean, whichever form you want to do it, femto, trans, PRK, or suppose you don't want to apply pressure, then do PRK. But I think I'd rather go for an extraocular procedure for such a small amount of residual refractive error. Now, in case it were larger, then an IOL exchange or a piggyback IOL. But in an IOL exchange, I'd always check the specular first. It is very, very important, because once that is on the southern side, it's a bad prospect for the patient. Secondly, if a haptic is not coming out, I'll cut that haptic and leave it there. I don't want the haptic, and leaving it there, if it's not loose, is not a bad prospect at all. It will stay there with the new IOL and nothing's going to happen, especially if it's fibrosed. I mean, those are the points basically. For piggyback IOL, then yeah, it's much smoother, but always for a much larger residual error rather than this much.
Yes, Dr. Ramurthy.
I would go for it. I don't know. Abhijeet is a great surgeon and a good friend, and he did the surgery beautifully. But then there's been a lot of zonular damage, which maybe the bag remain stable on the table. But if the patient has another 25 years to live, this entire back complex can drop off. So I would feel that putting back, especially when it's a plus 3.25 diopters, I'd go ahead and do a piggyback lenses. Now, Indian piggyback lenses are also available at a fairly reasonably priced, and just into 1.5 and put the lens, and first day the patient is quite happy. If it was a minus 3.25, I'd go ahead and do a laser vision correction. For hyperopia, maybe up to 1.5 to diopters, I'll do it on the cornea, but otherwise a piggyback lens. And I think that would have made the surgery much simpler, especially when it's a hydrophobic lens which has been there for 3 years. And if it had been a recent thing, 6 weeks, 4 weeks, and we realized that it is a biometry miscalculation, then getting this lens out is much more easier. But as if at all we had to do a exchange for some other reason, and it was a hydrophobic acrylic lens, as Swapna said, I would cut the optic haptic junction, leave the haptic inside, and just bring the optic outside. And especially with a 3-piece lens, the space that is occupied by the haptics is very small.
Dr. Vavikar, would you like to comment about IOL exchange for a 3-piece versus a single-piece haptic, single-piece lens?
I didn't get the question.
No, if you have decided to do an IOL exchange, the tips for the audience, what are the challenges in cutting a single-piece IOL versus a 3-piece? Do you feel there's anything extra to add here?
No, I think Dr. Ramurthy has covered all the points. Basically, if it is myopia, piggyback is the first thing which comes to mind, because if it is hypermetropia, and the IOL was very well centered in the back. And if it was myopia, probably either piggyback or LASIK.
Dr. Abhijeet, if it had been a single piece in the bag, would you feel there would have been a little more of a challenge than the ability you were able to cut the haptic and take the optic out? And
I don't think so, because the space out there is always there. So when you're pushing in a nice dispersive viscoelastic and using blunt instruments to dissect out the bag, it's pretty easy, in fact, for a single piece to come out compared to a 3-piece.
I would slightly differ on that, in the sense that, sorry, please go ahead.
No, sir. Please go ahead.
No, the haptics of the, just like the capsular rhexis margin gets stuck on the optic, the single piece haptics is also made up of the same hydrophobic acrylic material. And the addition to that is much stronger than the PMMA haptics of the 3-piece lens. Another aspect is, I think you most often use Alcon lenses. They have that bulbous tip, and that's where the addition is most stronger. And sometimes it's very difficult to release them. And that's the reason that you cut off the optic haptic junction and leave the haptics inside. Because separating that haptics from the fornices is quite a challenge, and it does damage the journal support quite significantly.
Yes, Anaga? Yes.
Just
very
one
well.
more lovely surgery, Dr. Abhijeet. I
Yeah.
just wanted to ask you, on table, if you thought you were not able to maneuver it and you thought that there was a one place where the zonular dehiscence has started to show, what would you have done at that point of time? What was your plan B? Would you put in a CTR and remove it, or would you pull out the entire bag and put in a iris claw? And there will have to be some plan B, no?
Yes.
So I always have all the lenses ready in such cases. So I have iris claw, I have scleral fixation, everything available at the same time. So I keep a CTR and a MH segment also standby. So if I would have had a zonular dialysis, if it would have been just 2 or 3 clock hours, I would have put in a CTR and cut off the haptic there itself using a micro scissor, especially the ones which are, I think, MTR. No, what are those? So,
Yeah.
Those goes through the side port, and you can actually cut off those things through the side port and remove the IOL completely after leaving the haptics in the bag. If I would have noticed even the slightest laxity, I would have put in a CTR any which way. So, irrespective of whether I'm able to get the IOL out or not, the CTR would go in.
In this case, in spite of removing the lens properly, would you think, sir, putting in a CTR, like you said, probably later on the zonular dehiscence would
So
show up?
usually when I'm doing the cortical wash, I hold my anterior capsule and I rub it. I'm actually polishing it. So when I'm doing that, if the bag is moving like in circular movements, even slightest, I assume that there is some amount of a zonular laxity and I put in a CTR. In this case, it was not there. So there was no CTR which was introduced.
Yeah, very well done case.
This is
Dr.
one direct question. You are not some youngster. I have to be generous too and be nice in the sense that one of the first presentations on piggyback lenses I saw in AIOS from you. I thought that was happened even before I started putting piggyback lenses in good numbers. Why did you resort to that? That would have made the surgery much more simpler than this.
Sometimes you need to challenge yourself as well.
First, don't challenge the patient's eye.
Yeah. So even the piggyback was it was ordered. So if I wouldn't have been able to exchange it, I would have put in a piggyback there.
Okay. Thank you very much, Abhijeet. Do stay on, and we look forward to your discussion.